Hi, everyone. My name is Kyla Hannington, and I'm the Public Outreach and Engagement Division Manager with the Prince George's County Office of Human Rights, the county's civil and human rights education and enforcement agency. Our office investigates complaints of civil rights discrimination, combats human trafficking, ensures equitable language access to county government services, and builds programming to educate on civil rights and social justice and to build community across the diverseness that is our county. With me today backstage, we're doing some tech, is Audrey Lau from Prince George's County Memorial Library System. They're one of our event partners for this series, along with the University of Maryland. Social Justice and Community, this partnership series, was brought to us by Dr. Chris Marsh with the University of Maryland. And it's a wonderful opportunity to look at social justice scholarship. It asks questions like, how does human rights research impact our communities? How does scholarship on human rights violations or issues of social justice have any meaning in our day-to-day lives? And what is being discussed, studied, and thought about in universities today? So in this series, we bring together human rights scholars in conversation about how their work illuminates human rights struggles around us today and what we can do about those struggles. So today, we're very excited to be welcoming Asiah Gayfield, presenting on Black women and prenatal care. Asiah Gayfield is a PhD candidate in the Sociology department at the University of Maryland. Her research focuses on Black women and girls, and her presentation today will focus mainly on Black women and prenatal care and infant mortality. She has a master's degree in public policy from Brandeis University and an undergraduate degree from Butler University in science, technology, and society. She lived in Prince George's County with us, like not me personally, but with all of us here in Prince George's County for 8 years until recently relocating to Washington, D.C. And it is our absolute pleasure to welcome her today in conversation. Asiah, welcome.
Hi, thank you for having me.
It's wonderful to have you with us. We're very interested to learn to learn what you have to share with us today.
Thank you.
Do you want me to put up your
Yes, please.
presentation? Okay, here we go.
Thank you. So I just want to start by saying thank you for having me. I am a library kid, so it's really great to be here with you. I grew up in St. Louis, Missouri. Today is actually 314 Day. So St. Louis's area code is 314. So we claim this day, March 14th, as our day. And so the libraries are absolutely what led me to my love of reading, my love of research. So I'm very happy to be here presenting with all of you. So today I'm going to tell you a little bit about myself. I already did, but I'll give you a little bit more. I'm going to give you some context and talk about Black women and birth outcomes. And then I'm also going to talk about the causes for disparities in birth outcomes, and then talk about prenatal care, and then also talk about my current research, and then give you guys some time to ask me questions. So about me, like it's been said, I'm a PhD candidate in the sociology department, which means I've been there for a long time. So I'm specializing in demography and stratification. So really what that means is that I specialize in counting populations, right? So demography is basically how we count populations, like the formalized counting. So you can think about the Census Bureau, which is also in Maryland, which, does the census every 10 years. That's counting people, right? And then also stratification is really a fancy new word to talk about inequality, right? So I think about how we count populations, and then also how populations are unequal. So all of my research really focuses on Black women and girls, which leads me to my research today, which is on Black women and infant mortality. And so I've also had the privilege of teaching at the University of Maryland. I've taught intro to sociology and also the sociology of gender. So I want to start off by talking about Black women and birth outcomes, right? So in 2022, the Black infant mortality rate was 10.4 deaths per 1,000 births, while the white infant mortality rate was 4.4, right? So starting off, we can see that Black women are 2.4 more times more likely to experience an infant death compared to white women. And so this disparity has actually been a long-term disparity, right? For the past several decades, Black women have been more likely to experience an infant death compared to their counterparts parts of other races, even as the US has seen a drop in the overall infant mortality rate, right? And so when we dig into this, we see that Black mothers with college and even advanced degrees have a higher infant mortality rate than white mothers who did not finish high school, right? So, what we're seeing is that this disparity affects Black women across the socioeconomic spectrum and even across the age spectrum. And this is a phenomenon that is really specific to African American born mother or African American mothers, right? So babies born to African born mothers, right? So babies whose mothers were born outside of the US but who are still Black have similar birth weights and similar birth outcomes to um, white mothers, right? So this is really a US African American phenomenon. And part of what we theorize is the reason for this is racism, right? It is the racism that Black women experience in multiple ways, and I'll get into that later, that is really the driving cause of this disparity. So I want to talk a little bit about infant mortality as a metric, right? So infant mortality is important on a personal level, right? Because it is a tragedy. Experiencing an infant death is something that any person, any family, any, not just the small family unit, but any extended family or even any community that has experienced this can tell you this is a tragedy, right? And so that's part of why it's important. But infant mortality is also a worldwide measure of public health, right? So, number one, it's easy to count and it's easy to measure between nations and across time, right? So, unlike other measures of health, we have infant mortality data from all over the world and going back decades, right? Um, but also, this is a measure of a nation's public health, giving the ability for women to have safe safe births where both the mother and the child survive is one of the basic functions that every medical system around the world should be able to carry out. And unfortunately, even with as much money and resources as the United States has, and as much as we spend for on healthcare and in our healthcare systems, the US actually ranks number 33 out of number 37. So we are really close to the bottom in terms of our infant mortality rate compared to our other similarly developed nations, right? So two things to understand about infant mortality is that one, we have this huge disparity between Black women and white women, right? But also, given that disparity and the rate overall, we are lagging behind our similarly developed nations, right? So our peer nations, think of really any other nation that you can think of that's developed in the same way as the US, like France, like Norway, all of those countries, we are doing worse than our peer countries on this very important measure of public health, right? And so part of the reason why infant mortality, this disparity between Black women and white women, is so persistent is simply put racism, right? And so I'm going to dive into three ways that racism has made this disparity so persistent. Um, so we're going to talk about racial stress, which is the weathering hypothesis. We call it weathering. We're going to talk about social racism and social determinants of infant mortality. And then we're also going to talk about racism in the medical system. So, the weathering hypothesis, right? So, originally, when we started studying health disparities, which is something that the public health community and um, other researchers didn't start studying until about the 1980s. Originally, when we started talking about the gap in infant mortality, that gap was blamed on the high rate of teen pregnancy among Black people. But we had a researcher, her name is Arlene Geronimus, who theorized that the health of Black women begins to deteriorate in young adulthood, which is in opposition to the accepted theory at the time, which was the developmental paradigm, right? So the developmental paradigm said that, well, of course, there's a higher rate of infant mortality between Black women, among Black women, because there's a high rate of teen pregnancy. Teen pregnancy is driving this disparity because their bodies are not developed enough to carry births to term or to deliver healthy, viable babies who are going to live going to live past 1 year of life, right? So Geronimus actually theorized that really what was happening here wasn't about so much about the undeveloped bodies of women who were giving birth as teens, right? She hypothesized and found that Black women's health actually deteriorates faster than white women's health, mainly due to the effects of discrimination, right? So inequality, racial bias, stress due to racism, and differential exposures to environmental hazards, right? So what this means, and this is borne out into the research, and I can talk about that a little bit more, what this means. And so when I said like Black women with advanced degrees and who are older have a higher risk of infant mortality than white women who are giving birth younger, what that means is that over time, right, Black women who are delaying birth because they're experiencing the stress of racism, they are on a cellular level deteriorating faster and aging faster. And so that is why we're seeing higher rates of infant mortality for Black women, right? And so the research that looks at this actually looks at DNA of Black women compared to white women and measures it's actually really cool DNA, right? So I'm holding my hand up because what they do is they take a cheek swab and they actually look at the DNA of white women compared to Black women and see that within the DNA, there's something called a telomere, right? And so every time your cells split, right, which is how we get new cells in our body, they split. If you think back to like high school biology, right? As your cells split, your telomeres, a piece of your telomere drops off. And every time a piece of your telomere drops off, that means your cell is aging. So on average, when they looked at these cheek swabs, on average, Black women had shorter telomeres than white women. And so this is what we believe is contributing to the infant mortality disparity, right? It is the stress due to racism, due to inequality. You know, when we look at the telomeres of white women and Black women who have the same socioeconomic status, who have the same level of education, who are the same age, who should theoretically be aging on a cellular level at the same rate, what we're seeing is that the Black women have the smaller, shorter telomeres. And we believe that that is due to the only other variable that they're experiencing that the white women are not experiencing, which is racial stress, right? So that's one reason for this gap. So another reason is what we like to call the social determinants of health, right? So you may have heard of this concept before, right? So the social determinants of health is really an agreed upon framework for how a person's social lived context affects their health, right? And so this is a concept that has been put forth in research to understand really what we as researchers are understanding is that health is not just about your biology, right? And when we see these health differences in racial groups, or we see health differences in age groups, or we see health differences in different parts of the country, right? it's not about biology, right? So when we see this difference in infant mortality rates between Black women and white women, it is not about the basic genetics of Black women versus white women, right? It's not about that. What it really is about is the differences in the social environments, the social context, and the racial stress that Black women are experiencing compared to white women, right? So, what does that mean for infant mortality? Well, so we can pick any one of these kind of pieces of the social determinants of health wheel, right? So, economic stability, how would that impact infant mortality, right? Well, if you are a mother who cannot afford healthy food during your pregnancy, right? That's going to contribute to your risk of infant mortality, right? If you don't have access to a safe home, right? If you live in an environment that is not safe physically or health wise, right? So let's say you are a mother, you're pregnant, you can't afford to live in a nice apartment. So you end up living somewhere where the air quality is bad, maybe there's lead paint on the wall and you don't know about it. That's going to affect your pregnancy, right? Healthcare access and quality, right? That's also going to affect whether or not you have a healthy pregnancy and can deliver a baby that lives past the first year of life, right? So we can think about Southeast DC, right? You all may have heard of, they closed a hospital a couple years ago in Southeast DC, and they closed the only prenatal care OBGYN facility in Southeast DC when they closed that hospital, right? That had a direct impact on the ability of women who lived there to give birth on their birth outcomes, and we know it did. I'm sure we can see it in the research. There were lots of articles about how that either caused women to lose their provider access altogether or to have to scramble to find new providers, right? So where you live absolutely has an impact on your health, and it absolutely has an impact on whether or not you um, can make it through pregnancy and deliver a healthy baby that is going to live. Um, so yeah, so that's the second part of what I wanted to share with you is the social determinants of infant mortality and how the lived environment, your lived context impacts health during pregnancy. And so I also want to talk about the medical system's contribution to infant mortality, right? So, number one, there's provider bias, right? So we know that we live in a racist, white supremacist, capitalistic, patriarchal society, right? I don't think we'd all be here gathered at an event called a social justice event if we didn't understand that or know that, right? So each of us has a bias, whether has biases that come from society, whether they're unconscious or not. And those biases come in the room with providers when they are giving healthcare, right? Unfortunately, right? We don't want that to be the case, but there have been studies that show that that is the case, that there is provider bias that exists in the medical system, and it exists in the prenatal care provider system, right? I think we would be naive to think that it didn't, given the way that Black women are talked about in popular culture, given the way that Black children are talked about in popular culture, right? So we can think about right now in DC, the way that Black youth, right, in DC and in the DMV in general, the way that Black youth are being characterized as criminals, as carjackers, as kids who need to be locked up, that has an effect on how people view pregnant Black women who are producing another Black baby, right? So if a provider has a bias, imagine what that does when a Black woman walks into a provider's office and she's pregnant and she's producing. If someone believes that all Black children are thugs, that they're all carjackers, that they all need to be locked up, imagine how that bias comes into the medical system, into the exam room when a pregnant Black woman walks into the room, right? We have decades, if not hundreds of years, of biases towards Black women and their reproduction in America, right? And so myths that have existed for years about welfare queens, about the uncontrolled reproduction of Black women and what that's doing to our society, that bias, those stereotypes, those ideas, they enter into the exam room with Black women when they come for doctor's visits. And if providers are not explicitly working to undo their anti-Blackness, that's going to come out in the exam room. It's going to come out in the appointment. It's going to come out in the level of care, attention that they give to Black women. And here's the thing, prenatal care, as someone who researches this, prenatal care is actually very variable, right? So when we think about a prenatal care exam, we have to understand that the provider is really a gatekeeper. And they're a gatekeeper to all types of services and tests and things that can help a mother while she's pregnant, right? And so I can speak anecdotally. When I tell people what I study, women tell me about their prenatal care experiences, and no woman's experience is the same, which, of course, we're all different. Everyone's pregnancies are different. But there is no standard of, okay, you're supposed to have all of these tests, right? You're supposed to have all of these. We have markers, developmental markers for, by this month, you should have experienced this. You're going to feel the baby kick at this point in time, right? But there's really no standard for what you should be getting. And so you may not get, your provider may have a bias, right? A provider may have a bias against a woman of a certain race or a certain socioeconomic background, and she may not get as good care as a woman that the provider doesn't have a bias against, right? Then we also have to think about how prior adverse health experiences, whether personal, familial, or community experiences, right, affect women's decision to go and get prenatal care, right? So, if you have had a prior adverse health experience, a prior negative experience with the provider, chances are you're going to be less likely to want to go back to the doctor, right? And so, in my research, I theorize that pregnancy is actually a motivating factor to make people go to the doctor, right? So, I'm sure there's a lot of us in this virtual room who have been sick, who have hurt themselves, who have been experiencing something, and someone told you to go to the doctor and you said no, right? You just were like, nope, I'm gonna walk it off. I'm gonna drink some water. You know, something you were just like, I'm not going to the doctor, right? Well, I believe that being pregnant, right, when you have a body, a person growing inside of you, that is a motivating factor to go to the doctor, right? Because you have another life that is dependent on you. But right, so you have that motivating factor of a baby, another life depending on you. But at the same time, if you've had an adverse experience, if you were discriminated against, if your grandmother went into the hospital and you felt like the doctors didn't do everything that they could for her, you might not want to go to the doctor. And so we have this kind of push and pull of, I want to go to the doctor, I want to make sure my baby's okay, I know I'm supposed to get prenatal care, but also maybe you don't want to go because of something you've experienced, something you've seen, right? And we also see this now with um, the news stories that have come out about Black women and their experiences birthing, right? So there are women who are like, I don't want the medical model of prenatal care, and they're foregoing it altogether. They're going to doulas, right? And so, or they're going to midwives, right? And they're foregoing the medical system altogether, right? And so this ties into patient fear of discrimination, right? And so if you fear that you're going to be discriminated against, whether because of your race or because of your socioeconomic status, right? So there's research that shows that if you have Medicaid, right, which we know is the public health insurance, right? Some people fear being discriminated against because they have Medicaid, which, lets the doctor and the provider know that this is a poor person, right? Some people fear being discriminated and they try to protect themselves in different ways. And there's a range of ways that people, particularly Black women, try to protect themselves. So, there's research that shows that some Black women dress up when they go to the doctor's office, right? They wear they make sure they are wearing their wedding ring so that they're not treated like, a woman who's unmarried and having a baby, which we know there are biases against that, right? They might carry their really nice, expensive Coach bag to signal I'm someone with money, right? But what if you're a woman who can't signal in that way, right? You may just forgo going to the doctor altogether, or you might delay going until, the end of your first trimester, the middle of your second trimester, when you've gotten up the courage to go. And then also, there is just plain old health system complexity or health insurance bureaucracy, right? Navigating the health system is, it's a nightmare, right? Navigating health insurance bureaucracy, it's a nightmare. And I am someone, my master's of public policy is in health policy. And I still struggle with it, right? So for people who it's not their job to study the medical system, for people who are not well versed, right? I'm sure any number of us in this room have struggled with this, have struggled with, trying to get a doctor's appointment, trying to get an appointment with a specialist, trying to follow up. And imagine if you are pregnant, right? So you're already, your system is already taxed from being pregnant. And you are, also, let's say, you can't take off work. You have all of these things that keep you from being able to navigate this complex system. And that can keep you from accessing care. And so these are all contributions to infant mortality and keeping women out of prenatal care. So yeah. So I did want to highlight a couple cases that you might have seen in the news, right? So there's a woman, Shalom Irving. She was actually a healthcare researcher who worked for the CDC. And she studied how trauma and the medical system, structural racism, and violence made people sick. And she was 36 years old when she gave birth, and she actually passed away while giving birth, which is why she's not present in this picture. And so I pull this out to highlight, and I'm going to highlight some others where this is an issue that impacts Black women who have education, who have done everything right. And so what I want you to understand here is that education, resources, all of this is not enough to protect Black women from experiencing infant mortality, right? And so this is a case. I also included the link if the slides are available after, I don't know, but so you can see that NPR did a story on her. And so I like to highlight her because she's someone who actually studied this and still experienced an adverse birth outcome and lost her life giving birth, which is something that shouldn't happen in a medical system as advanced and as resourced as ours. I also like to, oh, perfect. So I also like to highlight, so I'm in the Beehive. And so I like to highlight Beyonce because Beyonce experienced a very difficult birth with her twins. So like she said in her, this is from her homecoming concert documentary, she said, I was 218 pounds a day. I gave birth to Rumi and Sir. I was swollen from toxemia and had been on bed rest for over a month. My health and my babies were in danger. So I had an emergency C-section. We spent many weeks in the NICU. And so what I wanted to bring in here by highlighting Beyonce is that this is a woman who is rumored to be a billionaire, right? A Black woman who, with all of the money in the world, with all of the resources in the world, who is probably at the peak of her health, still experiencing an adverse health outcome, right? And so, again, driving home the idea that really nothing protects Black women from experiencing these outcomes. And then I wanted to bring in a few more people, right? So these are all athletes, right? So this is Allison Felix, Tori Bowie, and then Serena Williams, right? So Allison Felix and Allison Felix and Serena actually both experienced really difficult births. So Allison Felix, just like Beyonce, had toxemia, preeclampsia. And then Serena Williams actually had a blood clot after her after giving birth. And then Tori Bowie is actually another Olympic athlete who died giving birth, right? And so what I wanted to point out here is that these are women who are athletes whose bodies who their bodies are machines, right? Their bodies are in the top peak physical condition. But also, I want to point out specifically, like with Serena Williams, they still were not listened to by medical providers, right? So Serena Williams talked about in her article with Vogue, she talks about how she knows that she is susceptible to blood clots and she knows what it feels like. And even telling the doctor that she needed a heparin drip, they did not listen to her. They did not want to give it to her. Now imagine you are a woman in a doctor's in the hospital having just given birth, and you know that something is wrong, but you are not a multi-million-dollar athlete like Serena Williams, whose body has been studied and monitored. So you don't know exactly what's wrong. You can't tell the doctor, I need a heparin drip, right? But you know something is wrong. Do you think that, given what I've laid out here about Black women and the bias against Black women, do you think that you would be listened to? Right? Do you think, and that is not just an issue for Black women, it's an issue for all women, right? There's research that shows that all women struggle to be listened to be heard at the doctor, to be taken seriously, to have their pain taken seriously. And that's one of the biggest contributors, I believe, to maternal mortality, right? To the death of women and to morbidity, the sickness of women after giving birth, is that medical providers are not listening to women. And so I want to bring you to my current research. So I'm in the dissertation phase of my PhD, which is the last phase, thankfully. So I'm working on my dissertation proposal. And so my current project looks at Black women, prenatal care, birth outcomes, and social context, right? So I want to explore the variation in prenatal care utilization within racial groups and across social class. So like I mentioned, Black women of all socioeconomic statuses are susceptible to negative or poor birth outcomes, right? And mistreatment by the medical system. So what I want to look at is the differences in prenatal care utilization between, Black women of a high socioeconomic status compared to Black women of a low socioeconomic status. Because really, prenatal care, I've been talking about it, and it gets talked about like it's one kind of big thing, but really prenatal care is a series of doctor's visits And any woman can kind of fall out or come back into, right, these prenatal care visits. And this is why the way women are treated at the doctor's office is so important, because you can be pushed or pulled out of prenatal care at any moment, right? So the way a doctor treats you, if they treat you well, that pulls you back in. You're more likely to schedule your next appointment. If you get mistreated, you're less likely to schedule your next appointment. And then we have all of these other, it doesn't occur in a vacuum, right? We have all of these other factors that can keep you from going to prenatal care or make you go, right? So your social context, that's really important, right? The social determinants of health, that becomes really important for prenatal care, because it's a number of visits that you have to attend and follow-up visits. And towards the end, you're going to the doctor every week, which is important to make sure you're not experiencing the preeclampsia or the toxemia, those things that can pop up late in gestation and really threaten your life, the life of the mother, or the life of the infant, right? And so what I'm interested in looking at is that push-pull dynamic, and how Black women of different socioeconomic statuses are dealing with that, right? Because any Black woman can be discriminated against at the doctor's office, right? But a Black woman that has more resources should theoretically be able to say, okay, well, I'm getting pushed out of prenatal care. My doctor, my provider is not nice. I feel like I'm being discriminated against. I don't feel like I'm being taken care of. I can go find another provider. Whereas a woman of low socioeconomic status might have to say, oh, this is the only provider that takes my Medicaid. I can't find another provider. Or this is the only provider who has time that I can make for my appointments. And then that decision doesn't become find another provider. It becomes go back or not go back. And so I want to study that tension. And so the way that I'm studying this is I'm actually using two data sets, one from the CDC and then one from the Census Bureau, which kind of brings in my two interests, right? Population and also stratification. So basically, the CDC has a data set called the linked birth death data set, which has a record of all infant births. And then in the unfortunate case where an infant death occurs, they take that death record and they link it to the birth record, so that researchers like myself, when we can look at the birth records of infants who live and compare them to the birth records of infants who died, and see how many prenatal care visits on average do infants who live have compared to infants who passed away. What is the average age of mothers whose babies lived compared to mothers whose babies died, right? Things like that. Now, what I'm doing is I got permission from the CDC, and they gave me a confidential version of this data set that has location identifiers. So I have zip codes and I don't have zip codes. I have county codes. And I'm taking those county codes and I'm using that to link to the census data, so that I can now see the community context, that social context that I talked about in the where a birth occurs, right? So now I can compare the birth records of infants who live to the birth records of and death records of infants who passed away, but I can also compare the community context, right? So I can see how many hospitals are in the counties where infant mortality is occurring compared to the counties where it's not, where it hasn't occurred, right? How many what's the average, what's the unemployment rate, what are the education rates, what's the Black population compared to the white population, and what are the median incomes for those areas, right? So really getting into the social context and seeing how inequality, right, seeing how the social determinants of health are playing out in these communities where infant deaths are occurring. So, yes. Um, and that brings me to the end of my presentation. And now it's time for questions.
Okay, well, that was amazing. And I do want to let you know, in terms of people watching, in terms of questions, please type any questions that you have in the chat, because we welcome audience questions. We always welcome audience questions, but also this series is social justice and community. It's all about bringing this research out to you folks. So please, any questions? That was really, really interesting for me, Asiah. We actually do have 2 questions from the public already, but I'm going to take
Yes.
a host privilege, and I'm going to start with one. So
Okay.
one of the things that you said early on that I'm really curious about, and I'll be frank, surprised by, although I have a hypothesis as to why it happens. I'm going to get to the point in just a second.
Yes. Okay.
Is to do with that one of the things that you saw is that African-born women were experiencing similar, correct me if I'm wrong, African-born women giving birth in the United States were experiencing similar health outcomes to themselves and their infants as white women.
Yes.
But African American women specifically are having this very different experience. So, yes. I mean, I have a hypothesis, but you are the researcher. So let me ask you, like, what do you think it is behind that?
Well, so there's a couple things there, right? So number one, if you immigrated to the United States, you have not been here long enough to experience American racism, right? So that's number one. That's number one. Number two, there is some selection bias when we see who immigrates to the US, right? So if you are a family who is in another country and you are deciding to send someone to the US to earn more money, to start kind of planting that root to bring the rest of the family to the US, you're going to send your best, your brightest, your healthiest, your strongest people to the US, right? So we see this kind of, we call it the immigrant health paradox, where we see not just on markers of, of birth outcomes, but on other health outcomes, we see that immigrant populations in the US have great health outcomes that are on par with white Americans, who we usually see having the best health outcomes, because we're kind of skimming the cream of the crop from other nations. And so that's part of what we're seeing. Also, some of that hypothesis around the immigrant health paradox, other nations don't have some of the same unhealthy habits as we do in the US, right? So some people, one of the things that we found that is a real driver of that health paradox is smoking, right? So a lot of nations outside of the US don't have the high levels of smoking that the US does. So it's particularly when we talk about like life expectancy, like immigrant life expectancy, a lot of people come from nations where they don't have as high rates of smoking. They don't have as high rates of unhealthy food consumption, like fast food, things like that. And so we tend to see better health outcomes in immigrants. And that's across the health spectrum.
So yeah, that is really helpful. I mean, my hypothesis was to do with the weathering, which I think you touched on beginning, but it really makes sense.
Yeah,
I thought that was a really interesting data point. I'm going to ask our 2 audience questions that we have now before I continue, because I do want to share. This one came in quite early, so you may have kind of answered the question as you were talking, but I'm going to share it. This is from Miss Vivian, who's a regular viewer of our programs as well as the libraries. And so this was early on in your presentation, and she was wondering, do you know for sure, as you're looking at this research, do you have like absolute confidence that it's racism that accounts for these health outcomes?
Yes. So it's really hard to measure racism in research, right? Racism is, one of those abstract concepts that, we can't measure it in a survey. It's very hard to measure racism, right? But what we do is we do kind of, the process of elimination. When we say all of these things are equal, right? And the only other difference is racism, between a Black woman and a white woman, then we're seeing that we make the conclusion that it is racism, right?
Mm-hmm.
And I think that we also I'm a quantitative researcher, so I work with large data sets and numbers, but we actually do have qualitative research that shows that women are experiencing high rates of racism, right?
Mm-hmm.
Interpersonal racism, um, that they are picking up and that they see, and that there is an effect that bears out in the research.
Mm-hmm. All right, I'm going to share this other viewer question that came in. It was, has there been any research that shows that pregnant women who use alternative methods such as doulas or midwives have better outcomes than women who, stick with sort of standard or traditional American medical system?
I'm not aware of any research studies that have been done on that. I will say that it's actually really hard to capture that. And it's still a very, very small percentage of women who give birth who are using these alternative methods. A lot of what we are seeing, though, is women who are doing kind of a blend, right? So we see women who have a doula in the birthing room at the hospital to help advocate for them, right? We're seeing women. So I know of a hospital actually in New York where if you're there for their prenatal clinic, you have the option of not a dual, you have the option of a midwife or of a nurse practitioner, right?
Mm-hmm.
So it's not as straightforward in the research of not the research outcomes, but in actually researching it, because the doula or the midwife might be one person on the birthing team.
Right.
Yeah.
Okay, great. Thank you. We have another one, and from a viewer. So much, excuse me, I'm so sorry. So much of the medical community seems to be run more like a business. So is there a way for women to influence their own care or the care of others by taking themselves to doctors and institutions who recognize these disparities?
Yes. So I think you kind of put it in your question that, yeah, you have to speak up for yourself, right? I know that giving birth or, in prenatal care is a time where you might not feel empowered, right? You might have other things in your mind when you're giving birth. You're going through a lot of pain, right? And so that's where that trusted person comes in to advocate on your behalf. But that's also where, if you're getting medical care and your doctor is not treating you the way you want to be treated, they're not listening to you, that's where you start to shop around, right?
Mm-hmm.
And even if you are under resourced, I think that it's going to be harder, but it is worth it to take that time and look for a doctor who meets you there, who understands, who looks at you and says, I see that you are a Black woman or a woman of color, and I know the statistics, so I'm going to do everything I can to make sure that you have a healthy birth and that you and your baby come out of this alive, right?
Mm-hmm.
And I
Mm-hmm.
think that we are seeing more doctors and more institutions that are recognizing this and understand the statistics. We're also seeing more politicians and more, policymakers who understand this. And so, it's definitely something to think about, as you are shopping around for a provider, and also know that when you go into a doctor's office, you have power as well, right? Like, you can ask your doctor, do you know about this? Do you know about these statistics? Do you understand this, right? And if you're not getting the answer that you would like to hear, if your doctor doesn't sound like they have heard about this, maybe it's time for a new doctor, right? And I think that a lot of times, and I know I've been in this situation too, where when we go to the doctor's office, we kind of see that this person is, you know, they're the expert, they're the one with the power in the situation. But really, a doctor's visit is a collaboration between the patient and the provider. And so if your doctor is threatened or offended by you doing your research and you doing your homework, it's time to find a doctor who is going to collaborate with you, right? It's time to find a doctor who is going to understand that, oh, this is a person who's well informed, who's done the research, and this is someone who I'm going to collaborate with.
That's a great quote. I had to put that up there because I think it's really worth people keeping in mind. I was wondering, you said something. We do have another viewer question, but again, I'm going to take a little host privilege here and jump in. You talked earlier about these DNA tests and how looking at the difference in DNA and this kind of early wearing or breaking down of DNA. And I was wondering, of the way that trauma can pass like intergenerationally through DNA as well. Has your research looked into that?
Yeah, so I have come across that epigenetics, right? The intergenerational transfer of trauma, right? And it's really interesting because as a woman, your eggs form when you were in the womb, right? So you were part of you is there and present, not just in your mother's body, but in your grandmother's body. And
Yeah.
you were in your mother's body her whole life, right? And so that trauma, that if your mother experiences trauma, that's going to impact you, right, in her body. And it's really interesting because we talk about the intergenerational transfer of wealth, right? There's
Mhm.
also an intergenerational transfer of health, right? And so, you know, everything that is happening to your mother throughout her life is going to impact you and her ability. It impacts you because of her ability, her life when
Mhm.
she gives birth to you, right? And so it's absolutely important, right? Like I'm studying prenatal care, but really it's preconception care, right? It's what
Yeah.
health care did your mother get as a child, right?
Yeah.
In sociology, we talk about the long arm of childhood, and it's so true. Everything that happens to you as a child impacts you in the future. And so the health care that you did or didn't get as a kid, right? The care that you didn't get, growing up, that's going to impact you when you go to give birth as an adult. And so, in the same way that money is passed down, right? Health is passed down as well.
Mhm. Mhm. That's something that I just find so fascinating and also terrifying.
Yes.
The how much we pass down trauma.
Yes, yes, yes.
So we have a question from Renee Battlebrooks, who's actually the executive director of the Office of Human Rights, and she is joining us on YouTube today. And she is wondering: do we know if studies exist that look at other racial groups and health disparities?
Yeah, so there is so much work. Like I talked about the immigrant health paradox. That is actually a really wide body of research that looks at, you know, what other health outcomes, right? Specifically, looking at immigrants who have come to the US, right? There is a lot of health disparities work on Native Americans and American Indians. I mean, I could talk all day about health disparities, right?
Well, I think we should have you back to have exactly this conversation. Yeah.
I would love that
Mhm.
because I've studied this. I too get into health disparities, and
Yeah.
it's really interesting to see. I wish I could research it all, right? But they told me I had to pick one specific topic for my dissertation. But yeah, there is a wide body of research that studies health disparities and studies them not just from race, but looking at region, right? We see health disparities and differences in regions like geographic, right? We see health disparities by age, right? We see health disparities between men and women, right? So, the thing that I always teach my students is men have a higher rate of mortality, right? So men die younger, but women have a higher rate of morbidity, which means women get sicker, right? And that's really due to just very generally speaking, men are riskier in their actions, right? They also tend to be smokers, right? That's the group that tends to be smokers. Smoking is one of those things that's really key when we talk about health disparities. But men tend to be riskier, right? They tend to have more dangerous jobs, right? So you can think about the top jobs for men, right? Like think about construction work. Think about, back in the day when mining was a big thing, factory work, right? Things like that, right? Men tend to have those riskier jobs, right? So men tend to have more dangerous jobs and also tend to take more risk in their actions, right? Whereas women tend to be caregivers, right? So women are going to be teachers, they're going to be nurses, right? They're also going to be the ones taking care of their children when they're sick, right? So we see higher rates of morbidity, meaning sickness for women, whereas we see higher rates of mortality for men, right? So health disparities are all around. And so we see them really in almost any social group that you can compare, you're going to see a health disparity. Yes.
Well, I'm serious when I say we'll talk. We'll talk later.
Yes.
I'm happy to talk more about this. We're out of time, but there is one more question that I do want to ask you. It came in from a viewer, and what the viewer wrote is, why are more people not angry at these statistics? And I'm going to change that question just a little bit. I mean, I think it's a great question, but I'm going to do like a part two, which is, what are you finding? Like, is there a wave of like, rage to change this? Like, what are you seeing out there?
Actually, there is, right? So one of the things that's really interesting about doing this research is that when I tell people about this, one, women tell me their birth stories. So I've heard the gamut of birth stories and prenatal care stories, and have heard them even from the women in my family, which was very interesting to hear, my aunts and their birth stories, or my mom and her birth story. But also, I've had a lot of women in the past couple of years tell me, this is why I'm signing up to be a doula, right? So what I've seen is that women are angry about this, right? And they are taking it into their own hands to be a doula, to be a birthing coach, to go out and do that work, and to say, okay, the medical model is not working for us. I'm going to go and be a doula and take that into my own hands, which I think is great. I think that, to say, why are people not angry at these statistics? A lot of people don't know, right? It's become something that has gotten to the forefront. I think, like, the reason why I highlighted those, like Beyonce and Serena, is because we're seeing more, particularly as we see this happen to celebrities. It's getting more push, it's getting more information. But a lot of people don't know. And a lot of people don't think about it until it's time for them to go give birth, right? A lot of people don't think about it until it's time for them to have a baby, or until, unfortunately, a tragedy happens, right? I think that we don't, giving birth, having a baby just seems like something that is just so natural, so easy. Like, we think, well, women have given birth since the beginning of time. We're all here because someone on back gave birth. And so we almost think like, duh, it should be easy, right? Duh, it should happen. There should be no problem. But you often don't think about it until you experience that tragedy, whether yourself or a family member or someone in your community. And so, I say, one, people just don't know. But also, I think when people do know, that, galvanizes them to do something, even if it is just to be extra vigilant when they themselves go to the doctor or are giving birth.
Right. Well, this has been an absolutely wonderful presentation. I mean, it's very timely and important, and I'm really grateful you came and spoke to us today. For everybody watching, thank you very much for being here. We do social. Sorry?
Oh, I was just saying thank you to everyone. more. Thank you.
Yeah, it's great. And we do this every Thursday at 2 p.m. Again, it's a partnership between the University of Maryland, the Prince George's County Memorial Library System, and our office, the Prince George's County Office of Human Rights. I say every Thursday, but the exception is next week when University of Maryland is on spring break. So join us 2 weeks from now when we'll resume again. We also have lots of great other events coming up, including tonight. We are talking to an author about her new book, The Waves Take You Home. It's a pre-launch party at 7 p.m. tonight, again, in partnership with the library. We hope you can join us. Thank you again, everybody, for joining us. Thank you, Dr. Marsh, for bringing this to us. It is an absolutely wonderful series. And Asiah, it was wonderful hearing from you today, and we'll definitely be in touch.
Yes, thank you for having me. This is so much fun. Thank you.
It's been great. Good afternoon, everybody.
Thank you.